So for each patient sample, 3 glass tubes into the water bath, the same pool of factor VIII deficient plasma, 100 microlitres each tube. This is simply coming up to temperature. Fresh tip. Patient sample, 3 dilutions, really important. Every guideline which tackles factor VIII assays, WFH laboratory manual, CLSI guidelines, national guidelines, common theme, every guideline related to factor VIII that I'm aware of recommends testing patient samples at least 3 dilutions. I think 3 is perfectly adequate. I don't think anything is gained by testing 4 or 5. 3 is enough in my opinion, but important to test 3. I have here 3 dilutions of the first test sample. 0.1 plus 0.9, 0.1 plus 1.9, 0.1 plus 3.9. Make the dilutions into the test. 1 in 10 dilution, first tube, fresh pipette tip. 1 in 20 dilution, next tube, fresh pipette tip. 1 in 40 dilution, third tube. Warm into 37. So why 3 test dilutions? 2 reasons. One relates to the precision. There are several publications which have looked at the precision of factor VIII assay results and shown that there is much better precision, much closer agreement between results obtained in different centres is much better if in centres who use 3 test plasma dilutions. So for example, we ran a survey through our proficiency testing programme and we asked people, how many dilutions do you use in your factor VIII assay? I'm going to start the activation whilst we're talking. APTT reagent, first tube, and mix. Second tube at 15 seconds. And mix. Third tube. And mix. So we asked our centres, when you make a factor VIII assay, how many test plasma dilutions? And we sent them the same test sample for factor VIII assays. And when they sent the results back, so they all assayed the same control material, we divided the results according to whether the centre did 3 dilutions, 2 dilution, single dilution. The average result was very similar, but the variability was significantly worse in the centres doing a single test dilution. Actually, the CV, the coefficient of variation of results in different centres, was fairly close to 100%. It was enormously variable. Single centre, single test dilution. If you looked at the centres who did 2 test dilutions, there was a much better precision, much closer agreement between results in different centres, and not surprisingly, I think, the best agreement occurred in those centres who did 3 test dilutions. So, important for precision. There's an even more important reason for doing 3 dilutions. It absolutely improves the accuracy in the presence of interfering substances. The most common interfering substance, lupus anticoagulant. Majority of APTT reagents, which are used in factor VIII assays, the majority are affected by the presence of lupus anticoagulant. And if you do the first test dilution, in this case 1 in 10, this is a higher concentration of antibody present compared to the 1 in 20, where there's obviously a lower concentration of antibody, even to the 1 in 40, a lower concentration still. And people have shown very clearly that in the dilution with more antibody present, there's more interference. So the clotting time is falsely prolonged to a greater extent, leading to underestimation of the activity. So you produce an inaccurate result. And you only know about this impact if you've tested additional second and third dilutions, where the effective inhibitor is progressively lost, then you get closer and closer to the truth, closer to the real concentration, closer to an accurate answer. So the degree of inaccuracy is much, much worse, and there is the potential to seriously underestimate the real concentration and to falsely label a patient. So for assays which are performed with APTT reagents sensitive to lupus anticoagulant, it's really, really important. If the assay is performed with a reagent largely unaffected by lupus anticoagulant, then there still can be other interfering substances which cause this problem. So 3 minutes, calcium. For example, anticoagulants, like heparin, like the new direct oral anticoagulants, rivaroxaban, apixaban, dabigatran. All of these can cause interference and a similar effect, falsely prolonging clotting times, leading to potential for serious underestimation of the real concentration. And this is apparent only if you test multiple dilutions, 3 dilutions, so that you can see this non-parallel effect that we'll come back to when we look at some plotted results. So I think that it's a good recommendation in my opinion, and that's the reason why it's a consistent recommendation in all of the guidelines written in this area to the best of my knowledge. It's certainly there in the WFH lab manual, and I'm confident we'll retain it in any future editions. If you ask the centres who do a single test dilution, why do you do this? The most frequent reason that's given relates to cost. People say, but I don't want to spend the extra money on those extra dilutions, extra reagents. But I have to say, I think it's a false economy, because the financial implications of an imprecise or especially an inaccurate assay could be significant in terms of inappropriate use of blood products, concentrates, for example, I should say, which are, of course, extremely expensive compared to the cost of the laboratory assay. So I think investing a small amount of additional cost in the lab assay really pays back when it comes to the overall cost of the healthcare for that patient. I think it's a false economy, in my opinion. The difficulty sometimes is that the cost sits in different budgets in relation to laboratory diagnosis and testing compared to treatment budgets. This is a common problem. Okay, so the first test sample, 1 in 10, 1 in 20, 1 in 40. 81.5 seconds, 89.5 seconds, 104 seconds. So already you can see longer times than what we've seen for the standard. Longer times, lower concentrations. So the second patient sample is underway, 100 microliters of deficient plasma, each of 3 tubes, 1 in 10 dilution of test sample, first tube, 1 in 20, second tube, 1 in 40, third tube, and these are incubating. In a moment, when we reach the 3 minutes, we'll add the calcium. So if you think a little bit about the sample which is collected for factor VIII assays, we know that a number of different blood collection tubes are in use, and we also know that this can have an impact on results of APTT tests. So since these are APTT reagents we're using in a one-stage factor VIII, there's a potential at least for different results to be obtained with different reagents. Does the tube collection system, does that impact on the results? Actually, the data that's available suggests that results are interchangeable. Samples collected into the currently available commercial tubes will get the same result of factor VIII assays. So probably the tube is not having an important impact on the results which we obtain. Of course, it's important that the tube is properly filled and safely handled. If we get hemolysis during the collection and processing, 3 minutes, calcium, if we get hemolysis during the collection and processing, then this can affect the results of APTT, and they also have an impact on the results of factor VIII assays. Hemolysis in the sample, artifactual hemolysis, that can lead to activation of clotting factors. We may have enzymes present. We may have some activated factor VIII. generated in the sample. And this can affect the results. It can influence the degree of parallelism between the dose-response curve for patient compared to the standard. These may not be parallel where active clotting factors are present. So that's another reason why 3 dilutions can be really useful, so we can assess this. Probably the most important pre-analytical variable in relation to factor VIII would be storage of the sample if it's deep frozen. And I already mentioned we absolutely should avoid storage at -20, particularly in domestic grade -20s. Just waiting for the third tube, third dilution, and it's gone. So we've got clots now in all 3 dilutions. Progressively longer times, more diluted, progressively lower concentrations of factor VIII. Clotting times on test number 2. First dilution, 67 seconds. Second dilution, 70 seconds. Third dilution, 78 seconds. 1 in 10, 1 in 20, 1 in 40. So we've done a third patient, 3 dilutions, 0.1 of deficient plasma, 0.1 of 1 in 10, 1 in 20, 1 in 40. And the clotting times for the third patient, the first dilution, 141 seconds. The second dilution, 141 seconds. The third dilution, actually 142 seconds. So actually very close. Doesn't always work out so close, but nevertheless, the same clotting time in each of the 3 tubes. So what does that mean? It means that we've not got a differentiation. It means that the level of factor VIII in those tubes is below the level that would have an impact on the clotting time. What does that mean? Well, we know a factor VIII deficient plasma which completely lacks factor VIII with absolutely none present, no genetic capability to synthesize factor VIII, but we know a sample from such a patient, we still obtain a clotting time, at least in the APTT. And that's because of the artificial nature of the reagents. We're running these reactions here in a very artificial way. Remember, in the APTT reagent, we're activating with kaolin or sealite. These are not physiological activators. Kaolin, clay particles, sealite, effectively sand, ellagic acid, not physiological activators. We're running these reactions very quickly in a very artificial way, and under those conditions, we obtain clotting times, even in the absence of factor VIII, so a severe haemophiliac APTT. Incoagulable? No. Does it clot? Yes. 90, 100, 110 seconds maybe. And it's the same here with this factor VIII deficient plasma. We will obtain a clotting time, and that's what we've done. So at this moment, for that patient, 140, 140, 140, we don't know what the level might be, and we'll look at this when we make the plot. Just now, I'm running a new calibration, a second standard curve. It's the same reference plasma, 3 new dilutions, 1 in 10, 1 in 20, 1 in 40. Prepared these dilutions afresh with new tubes, a new buffer. And I'm running this at the end of all the patients. So as we get to 3 minutes, calcium to the first, 1 in 10. 15 seconds later, 1 in 20. And mix in the third tube. So during the assay, the very first sample we tested, reference plasma, calibration plasma. And the very last is a repeat of the same reference plasma. New dilutions, but the same reference. So what's the purpose? We need to know if any of the conditions have changed during the assay. whilst I'm talking, whilst I'm pipetting, have I introduced contamination between any of the reagents? Has the water bath stopped working during that time? Have I turned it off by mistake? There could be changes during the period of the assay. And if we run a standard at the end, because we run a standard at the end, as long as those clotting times are very similar to the clotting times at the beginning, we can safely assume that the assay conditions have stayed constant during the time of that assay. We don't expect to see identical clotting times, but we hope to see very similar clotting times at the end. And it's an important question in order to confirm the validity of the assay. If we were running this assay on an autoanalyzer, in which the test and standard are analysed at the same time, then it's not so important because we don't see the same opportunity for drift in the assay system, for change in the reagents. If there's a delay in the time, and there is for most analyzers, then we should also then finish with a repeat calibration in the same way that we began the assay with a calibration curve. So this is a repeat of the standard that we began with. Again, 1 in 10 dilution, 1 in 20 dilution, 1 in 40 dilution. And the 1 in 10 dilution at the end, 64 seconds. If you remember at the beginning, 63. The 1 in 20 dilution, 70 seconds. At the beginning, 69. The 1 in 40 dilution, at the end, 78.5 seconds. Now the one at the beginning was 85. So that's really quite a different clotting time. So we have to ask ourselves, how much of a difference do we accept? And we really need the standard at the end. If it were plotted as though it were a patient, it should be within 10% of the standard at the beginning. The clotting times should be very close. So 64, 63, that's an acceptable difference. 69, 70, also an acceptable difference. 78.5, 85, that's not an acceptable difference. Something is wrong with one of those clotting times, and we'll know which when we come to the graph paper to make the calculation. Something's gone wrong somewhere in one of those tubes. And it's sort of known for that to happen when we're running a test manually in this way. It's another reason why we make a calibration curve at the beginning and at the end. So we've got, because there is a close agreement between two of the clotting times at the end and the beginning, we can take an average of those 4 clotting times, and we'll know from the graph paper which of the other two is more likely to be the correct time. So I think it's really important to do this.